Hi, everybody. I'm Naomi Fogel from Lurie Children's in Chicago, and I'm excited to share with you kind of our work in progress on food insecurity screening. For those of you who weren't able to attend the meeting last year in Chicago, I'll share with you a little about our program. We're based on the north side of Chicago. We, oh, sorry, well, whatever. We have about 8 total diabetes clinic sites around the city. We have about 1,200 established type 1 patients. About 50% are public aid, and a little under 50%, about 48% minority race or ethnicity. We know a lot of data already about food insecurity in diabetes. We know that rates of food insecurity in type 1 youth and young adults are higher than in the general population. About 18% of youth and young adults with type 1 report food insecurity compared to about 14% in general US households with children. Food insecurity is associated with other adverse consequences of type 1 diabetes, like poor glycemic control, increased risk for DKA, and more ED visits. Type 1 patients with food insecurity are less likely to adhere to fiber and sodium guidelines and are more likely to have trouble getting insulin, technology, and appropriate diabetes education. Pediatric type 1 patients are not consistently screened for food insecurity, and when they are, it's not always addressed. So there's a validated 2-question food insecurity screening tool called the Hunger Vital Sign that has been part of our diabetes pre-visit questionnaire since around 2021, and you see here a screenshot from our pre-visit questionnaire. A patient is considered at risk for food insecurity if they answer either or both of those questions with anything other than never true. To try to figure out how to address food insecurity screening, we started by looking at how frequently our patients were getting screened. We looked at 1 year's worth of patient visits on the left, and we found that 73% of visits had a food insecurity screener that was completed at the visit in the light blue. On the right, we looked at each patient, like patients versus visits, followed in our program and found that 95% had a screener completed somewhere, whether in clinic or somewhere else in the hospital system, at any point within the 6 months prior to their most recent visit. And then of the patients who filled out a screener on the left side, 5% had a positive result when you look by visit, and then at the patient level, 4% had a positive result. So you can see that patients probably screened positive at multiple visits. And when we looked more closely at the positively screened patients, we found that only 15% of positively screened patients received any intervention at all. And that could include something like a social work consult, a referral to local food pantries, or arranging for home food box delivery. We had previously had some funding for each family to get up to 2 home deliveries. So we decided to focus on increasing the frequency of screening to as close to 100% as possible, but also increasing the frequency with which we would intervene on positive screeners. Our key drivers revolved around screening difficulties with the workflow, resource barriers, like the fact that we have 8 sites and only 2 social workers, and psychosocial barriers, like people just being uncomfortable talking about food insecurity. And since we already had the pre-visit questionnaire built, we decided to first focus on optimizing the use of that pre-visit questionnaire. And then we came up with some other ways to address food insecurity directly with the help of our dietitians and also by creating a food pantry. So here's our process map for the screening efforts. So ideally, patients would have filled out that pre-visit questionnaire before they got to clinic, but if they didn't, then the point of service staff would remind them to fill it out. And if they still don't fill it out, or for some reason they can't, they don't have MyChart, there's a paper version available in both English and Spanish. And then once that's completed, the MA and the nurse and the provider are supposed to be checking the results and referring to social work if it's positive. If there was a positive result, the social worker would do an assessment and provide the resources that I mentioned, like the referrals or the home food box delivery. Unfortunately, earlier this year, the home food box delivery program ended. And even though the referrals are helpful, we really wanted to have something more immediate that we could do in clinic. So we coincidentally, around the same time, received funding to create a diabetes patient emergency fund. And so we were able to use some of that funding to create our own food pantry in our clinic. So it's very simple. It is housed just in a cabinet above a workstation at our busiest clinic site in the city. And it has little bags inside that we restock at small intervals. And inside the bags are the items you see here. Like I said, get deliveries every couple weeks, and each bag it costs about $15. And then along with the food items, we paired this with very targeted, specific education from our dietitians. We have carbohydrate counts in English and in Spanish for the items in the food bag. And our dietitians also created some recipe cards that are included, tuna salad, black bean salsa, and oatmeal energy bites that use some of the items and also have detailed carbohydrate counts. And then we have a dot phrase that we can enter in our own note very quickly to say that the social worker was consulted and that the food pantry was utilized. So this shows the percent of patients screened each month for the past year. It's been about 6 months since we started our interventions. And this is visit level data. So you can see in the 6 months since starting the interventions, we're still at about 75% screened. And same with the percent positive, we're still at about 5% positive. I did think the little spike in August was kind of interesting, maybe coinciding with the start of school. Here we see the actual number of patients that were screened positive per month, with the light blue at the bottom of some of the bars showing how many received any intervention, and then the percent receiving the intervention in that month is above each bar. And so these are, again, small numbers, but we think that since the interventions began in May, that percent is kind of trending up in terms of more patients receiving interventions. And then the little red line at the end shows the number of patients who received a bag of food from the pantry. And you can see that they're not exactly the same as the number who received an intervention. It's because some patients were referred to the pantry outside of the screener. So lessons learned so far, we still have work to do, but we do need to continue to take multiple approaches to screening for food insecurity. Having food available in clinic at that very moment was important to further reduce barriers that families face around outside food pantries. Most important, it was so incredibly valuable to have not just the social worker involvement, but also the dietitian involvement for education and other support. And so our next step is to sort of solve this notification issue. Like, even though we have so many people that are supposed to be checking the screener, there are patients who are getting missed who screen positive. And so we're working on building an automated notification into Epic that will go directly to the social worker when someone does screen positive. And then we're also going to try to expand to our other clinic sites, but there's some big barriers to that. And finally, we're also beginning to look at the food insecurity data for our other diabetes populations, like prediabetes and type 2. And that's it. Those are my references. And big thank you to the high-risk diabetes food pantry team.
Thank you so much. Questions?
I don't have a question. I just want to say that these are really beautiful initiatives that you implemented, and just being able to really use some basic foods to create these bags is really incredible.
Thank you.
Yeah, I agree 100%. I'm curious, for the people who screen positive for food insecurity, there's a food shortage issue, not for food quality. Is there higher rates of hypoglycemia in those patients?
We haven't looked at that yet, but that is sometimes how some of these things come out. Where I said, like, people are picked up outside of the screener. It'll either be like by the nurse educator when they're talking about trends, like, oh, well, why do you have these sustained lows overnight? It might come out that way. Or if the dietitian's talking to them and saying, like, I recommend higher fiber foods. I recommend brown rice. And they're like, well, we can't really buy brown rice. And so that's how some of these other people are being picked up. So we haven't looked specifically at that question, but probably.
I have a quick question. So, as we all know, it's very, like, a clinic day, it's very busy. A clinic appointment is very busy. So how was this integrated into the clinic process?
So a lot of it was talking to the point of service staff and having them sort of be that point person. A lot of it was, like with a lot of things, just reminding people, hey, we have the screeners, hey, we have the food pantry. And then sort of duplicating efforts, like I said, like we're all supposed to be checking the screener, between the MA, the nurse, the doctor, and the even the dietitian, like we all have access to check it. Unfortunately, it's still getting missed. So we haven't quite solved it yet, but we're hoping to sort of layer that approach.
Other questions? Thank you. It's a great initiative. Thank you so much.